Productive Dentist Academy podcast network.
I've been doing this long enough now that there's no magic. If you're out there listening, there's nothing I do that you can't do. But one thing we do is we train on it and we practice it, we rehearse it, and it's not a script, but everyone on our team is on the same page. We do risk factors that Dr. Coyce taught and that Bruce Baird teaches, and we communicate those to our patients in a system. So when we have a patient come in, they know our philosophy. They know we want to lower risk for their overall health and for their mouth. I like to look at the patients and say, if I could predict what you're going to look like in 15 years,
wow,
and I like it, keep doing what you're doing. It seems to be working for you. But if in 15 years we see that you have the potential for a lot of problems, what do we do to change? Because you don't want those problems, right? So if we can eliminate those problems, then it's there. So there's always two phases for a treatment in our office. It's one, fix the damage you have done to your teeth. Two, what do we do to lower the risk of that damage? And that's our philosophy. So there's no script for us. It's just talking to the patients about that.
Welcome to Investment Grade Practices Podcast, where we believe private practice dentists deserve to get the lifestyle today while building an asset for tomorrow. Join your host, Victoria Peterson, to design the practice of your dreams and secure your financial independence. Let's get started.
Welcome to another edition of the Investment Grade Practice, and this series from chairside to boardroom. That was my path from dental assistant and hygienist into practice consultant and CEO. And I'm so thrilled to have Dr. Wade Kifer with us today. Welcome, Wade.
Good to see you, Victoria, again.
Oh my gosh, we've been friends for so long, I can't remember a time where we weren't friends.
Yeah, if I recall, it's about 2009 or 10, somewhere back in that range. So a long time.
Nearly the turn of the century.
That's right.
Well, today you're here as part of our Clinical Calibration Institute faculty. I wanted to get this right, you're part of the Coyce Center faculty. What's your specific title there today? What do you do at the Coyce Center?
Well, I'm a clinical instructor at the Coyce Center and a course facilitator. So I go up and try to help with the treatment planning and occlusion course a few times a year. So just try to help out and give back as much as I can up there.
I love that so much. And it's been great to watch you from Coyce student to Coyce mentor to instructor. It's been quite the journey. And one of the things that you say to me all the time is, yes, I can nerd out on the science, but the science doesn't matter if you don't know how to communicate it to your patients. And that's what I want to get into today in this episode, which we're titling Case Acceptance Isn't a Script, It's a System. And I know you're very systematic and you do have scripts, but you've also taught me that if patients are saying no, you're not losing them because of that. You're losing it because you never got aligned to what yes really looked like. So I'm gonna give you that as your jumping off point. How do you keep case acceptance aligned with the team in your practice?
Well, I mean, it's not one thing, right? So case acceptance doesn't start, like you say, a line or anything. So first we had to have our philosophy. And I mean, not to sound cheesy, but it's not like sitting down and writing down your philosophy or anything. But for us as a team, we're all on the same page. You know, we meet monthly, probably 5 to 6 hours talking about everything we do. I always say, John Coyce taught me how to do high quality dentistry, but I wasn't doing it even when I learned it. And I give Bruce Baird a lot of credit for teaching me how to communicate it. So for us, I've been doing this long enough now that there's no magic. If you're out there listening, there's nothing I do that you can't do. But one thing we do is we train on it and we practice it and we rehearse it. And it's not a script, but everyone on our team is on the same page. We do risk factors that Dr. Coyce taught and that Bruce Baird teaches, and we communicate those to our patients in a system. So when we have a patient come in, they know our philosophy. They know we want to lower risk for their overall health and for their mouth. I like to look at the patients and say, if I could predict what you're going to look like in 15 years,
Wow.
and I like it, keep doing what you're doing. It seems to be working for you. But if in 15 years we see that you have the potential for a lot of problems, what do we do to change? Because you don't want those problems, right? So if we can eliminate those problems, then it's there. So there's always two phases for a treatment in our office. It's one, fix the damage you have done to your teeth. Two, what do we do to lower the risk of that damage? And that's our philosophy. So there's no script for us. It's just talking to the patients about that. And the hygiene is worried about the risk for your overall health from your gums. The whole office is looking at occlusal risk. For example, if a tooth's broken, did it break because there was a caries problem, an erosion problem, or a bite problem? And if
Yeah.
we control that risk, then we do it. Because I also tell the patients, if what damaged your teeth isn't fixed, my restorations won't last either. So we take a philosophy where the whole team is on the same page and we meet on it. And if you're anything like most offices, it's like just because you tell a team once, out of sight, out of mind. We're going over the same things every year with our team, reiterating and reiterating, and then over time, it just starts to sink in. So it doesn't happen overnight either. It's a lot of work, but it's rewarding and it makes things work a lot smoother.
Well, you giving a success clue here, and on investment grade practices, we're always talking about what makes this business more valuable. And part of that is team alignment. I mean, without team alignment, revenues are up and down. Depends on how many days you work, depends on who showed up to work, all of that.
Mhm.
And it's funny, you and Jackson Bean and John Ehlers, I can just keep going down the list. I'm seeing you in my mind's eye. You all say the same thing. We have half a day a month that we're doing this. Now, Jackson will say we do it poolside with adult beverages. I don't know what they do in Arkansas in your practice, but you're not poolside in the winter for sure.
No, 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 not in the winter. It's beautiful now, but not in the winter.
Yeah, I love it. And so you're doing this in Arkansas, right? So do you mind sharing just to give some context around what your collections are annually or production per hour, anything like that? Like where you were maybe 5 years ago, where you are today? Is it consistent? Does it stay strong? Does it grow?
Yeah, I mean, we're like any office. A couple years ago we were stale, so we didn't go up. We're up a little bit this year. But when I was at PDA, I was at 300 an hour,
Wow.
and now I'm over 1,200 an hour, just personally myself. And as much as I like the meeting time, and people say, "Well, I don't have time, I can't put it in." I mean, if you add up all my doctors and my 4 hygienists, we're probably 3,000 an hour. And we're doing 8 hours of meetings a month.
Yeah.
So we're giving up $20,000 of production time to meet.
Yeah.
And so that sounds crazy to some people, but I would say we wouldn't be that productive per hour if we didn't do it, right? And so I always tell people, put it on the schedule. 6 months from now, just start with 4 or 5 hours a month. You don't even know what it is, but if you add up your hourly office, it almost hurts to take that time off. But at
Right.
that point, I will then come up with what the topics need to be. Where are we struggling? How are we not in alignment? Because I don't want to waste the time either. We want to be productive. Now we have fun too. There's always one meeting a quarter where we just surprise the team and say, "Hey, we're going bowling."
Yeah. Yeah.
For a couple hours or whatever. And you need to do that too. But, we'll meet tomorrow. We have a 2-hour meeting. We're taking an hour out of lunch and an extra hour. So we're like losing 1 hour of production. But that time is important. And that time is what allows us to grow because we're doing philosophy. We try something new with collections or finance plans. The whole office has got to be on the same page because if you're not, you just look like you're, I don't know, not in sync. It's just not smooth. You know,
Yeah.
um, we talk because I mean, my average treatment plan given to a patient's over $6,000, and it's patients that need a filling. So when your average is that big, you're doing a lot of 10 and 15 and $20,000 treatment plans. You can't fumble through those. You don't go to Chick-fil-A and they give a $10,000 treatment plan. If you're going somewhere high end that's going to give you a big treatment plan,
Right.
It's got to be rehearsed. It's got to be practiced. It's got to be right.
Yeah, I love that. So, I'm gonna slow this down because you dropped so many golden nuggets there, and it's on this topic. It's like case acceptance is not a script. It is a system, and part of your system is team training, and that is literally why Bruce and I developed the Clinical Calibration
Yeah.
Institute. Like, we didn't even realize until about 5 years ago that's what we were doing. Like, as you and other people were coming through coaching and we'd say, "Okay, well, is everybody on the same page with this? And let's, like, go through a form." And you've really taken this to an art form. You're like, here, let's all look at this one case and how would we treatment plan it and what did we miss and did we get bite guard, no bite guard? Do they need fluoride? Are they hot based on their risk? So, just in the beginning, we would have offices just monthly pull a couple of cases and go through the case and get everybody, which seems silly. Like, why would I get a brand new employee who's working at the front desk even attempt to write out a treatment plan? Well, because they've heard, they listen in the hallway, they pick up things, and that's gonna be the person the patient asks, "Should I have this
Mhm.
time?" So it's always gonna land on your least experienced, least knowledgeable person to kinda close the loop, sometimes and say, "Man, I trust the doctor." And in fact, we sit down each month and we go through this, like, even your newest, youngest do that. So that was a huge piece that you dedicate the time to training, and that's how CCI got born, because think about it. I mean, well, you tell me, you're COIS trained, so you've got a master caries, perio, you've mentioned occlusion several times, airway is now standard for comprehensive exam, right? So caries, perio, function, airway, aesthetics, emotional risk, like there's 5 or 6 things you have to master. So, as a clinician, how many years and how much time did it take to say, "I'm really feeling good about the biological and lifestyle risk of caries and how to manage that. I've got my perio dialed in, I've got function, occlusion dialed in." What does it take to, like, be at the top of your game?
Well, I mean, I was up at the course center last week and I had someone that basically said, well, you've made it. And I said, yeah, I'm further along than you are. But when we just go back to the meetings with the team, we meet with the team and we spend 3 hours and we talk about perio for those 3 hours. And that seems like a lot. They still don't know a fraction of what you know in 3 hours.
Right.
Every quarter we add something. We may spend the rest of that quarter just doing perio. And it's not that we're not neglecting everything else, but it takes time. So if you can just get your team better at one thing a quarter,
Yeah.
and then you look up 4 years later, 5 years later, and you're almost just a master at all these things. But you can't teach an entire team, and you yourself can't learn an entire occlusal philosophy or anything in a month, right? It takes time. So, I mean, I have the benefit of saying, I've been doing advanced education even out of dental school since 2008. I graduated in 2003. And so it's easy to say, well, you've mastered a lot of different things. And I still have a lot to learn.
Right.
Right. And so it's tackling one thing at a time and going, okay, I went to this class. If you will go to a class or go through PDA and say, there was a lot of information. Let me start here and master that. And there's almost this sense of accomplishment of, oh, I got better at that. Now let me go tackle this. And so each year you get a little better, your production goes up, your patients get healthier, all that goes in. And then that's almost there, but you still need a review on some of those things that you've mastered too. So especially as you bring new team in and everything else. So that's what I would say is it's not overnight, and a lot of times you look up and someone says, well, you've made it or you've done this, and you'll never feel like that until someone
Right.
says that to you. Then you look back and you go, well, I have done quite a bit of stuff. But in the process, you're not thinking that way, so you just have to do it.
Well, and there's some listeners on this podcast going, "Well, good for you, Wade Kifer. You're a COIS instructor. I'm not. So where do I get the training materials to train my team like that?" That literally is the birthplace of CCI. Is
Yeah.
we're so blessed to have you and Kim Cooch, who does the Carries research for COIS. Dr. COIS has generously allowed us to use his medical history as an icon, to talk about how to integrate medical dental histories. So all of this training is online. We walk you through some of those team meetings we're helping, like CCI has on its campus, outlines and facilitator guides for staff meetings from an hour to 5 hours. We have virtual trainings you can do, masterminds you can do, communities you can tap into. Because unfortunately, not everybody's Wade Kifer and they know how to teach all this stuff.
It can though. I mean, I got into teaching this stuff only because I was there learning and giving my experiences. And someone said, well, that's neat. So then you're on stage. But I'm there on stage some teaching, but then I'm talking to Michelle about the Perio program, and Michelle's teaching me stuff. And then I go back and I implement some of it. And then I hear something new. And next time I talk to Michelle, I bring up something. She goes, well, that's really good. And now we're co-collaborating. Right, and it's just being around people. So I know you're wanting to get mastermind groups going. I know that's getting rolling right now and everything. So we learn from each other too. And everyone, bunch of people can go to a class and listen, and everyone picks up something a little bit different.
Yeah.
Right? And some people have natural skills in one area versus another. And so that's what's the great part is when you get with colleagues and meetings and stuff, a lot of the learning's in the hallway,
Oh, yeah.
getting together and talking and like, oh, I picked up, oh, I remember them saying that, but that didn't click that way.
Right.
So, I think that's a very valuable part of all this.
Yeah. And thank you for bringing out the masterminds and communities. It's a very different experience being in a curated group of like-minded folks
Yeah.
versus just jumping into Dental Town and asking a question. Like, that's two very, very different things. All right, bringing back to this topic of case acceptance and script or no script. There's a system, there's a lot of training behind it. I get that. But there are scripts. I know you've also said, "Oh my god, my team rolls their eyes every time because I say the same thing every time." So give us some of your, things that help you connect with patients during the new patient exam when they might be a little frightened or embarrassed. What are some of your takeaways that you can give us today?
Well, I've said this line before and it gets a laugh, but we have our scripts and our philosophy, and we've explained that to patients. But then it's really the linking. I know Bruce talks about the linking, and I always dig down deep. And I want to get deep into their why and why they have the problems. And I always say, if I can get the patient to cry, I've won. And that sounds bad because I'm not trying to make them feel bad, but if I can get them to connect on such a deep emotional level, if they can afford the treatment, they'll do the treatment.
Yeah.
Because whether it's the embarrassment, frustration, just imagine your patients who've come in and every time they go to the dentist, because I know you hear this, please don't find anything today, doc.
Mhm.
Please don't. Like your job's to not find something. So then you feel guilty. And so when they do that, I turn around and go, I'd be frustrated too if every time I came in, you had a problem. I had a problem. So I understand your frustration. So I want to get on their side. And now all of a sudden it's not, don't find something, doc. It's me on their side, not me against them. So if I could say anything, it's how do we link with the patients enough that we're on their side? We don't want to find anything either. And if we do, I'm the solution to their problems, not telling them they have problems. Let's not just fix the tooth. Let's figure out why this is happening. Now, don't be wrong. Some people just need to pick up a toothbrush, but we all have patients that do crappy jobs and don't have problems. So what do we need to figure out? Let's get on the patient's side emotionally. So it takes energy. That's why I can't do this 5 days a week every week because it's emotionally draining for me and my coordinators and my assistants because we're in it with the patients, but it's way more rewarding doing it that way.
I've also heard you say to patients, I love the linking and all of that's like in our first course on how to do that, but you actually give them a common enemy. This isn't your fault. It
Yeah.
could be. Pick it from there. Like you tell patients, like, man, whatever I see, just know it's probably not your fault. There's other things happening here.
Yeah. And so when we get a patient who's got problems, one of the lines I always use with patients is caries cavities is a bacterial infection. Periodontal disease is also a bacterial infection. If it was all how well you did, you'd either have both or neither. And
Mm.
so many of our patients have one or the other, meaning your immune response has a lot to do with whether or not you're getting these things. And so I will tell patients all the time, I'm sure you have friends that do worse than you do taking care of your teeth and don't have your problems. I'm sure that, you know patients that took great care of themselves and end up with cancer. And you don't feel guilty if you get a medical diagnosis. Now, I mean, if you smoke and get lung cancer, yeah, it's probably your fault. But a lot of things happen to us and we don't feel guilty. Except when we go to the dentist, we always feel guilty. So in this case, we're going to figure out what works for you because it's not fair. Sometimes you have to do things extra to keep your mouth healthy than your spouse, for example. All the time was a spouse that never flosses and doesn't have the problems the other spouse does. And I'll say, that's not fair, but that's the way you are. That's your immune system. So it sucks, but we're here to help. We're going to figure out what you have to do to stay healthy. And that's different for every person. So don't feel guilty.
Well, so many light bulbs going off in my head in that one vignette. And, I think at our best, that's where medical and dental care is going, is individualized care.
Yes.
And I, I love that that was a new aha for me. They either have caries or perio, both or neither. Like there's a range here and we've got to
Yeah.
figure it out. It's kind of like Pete and I, my husband Pete.
Oh, yeah.
Pete could eat anything, right?
Yep.
Like for breakfast, he had an egg, he had sausage, he had those frozen hash browns, he had black coffee. And I'm thinking, oh my God, I would die. If I would literally die because I'm allergic to eggs, I'm gluten free, I'm this, I'm that. And so I'm like, look, honey, you could have my breakfast, which is broccoli, asparagus, steamed with sweet potato and some mango. And I'm thinking, yum. And he's like, that is disgusting. And so, but his biology, my
Yeah.
biology, very different. Very.
And I use that exact same line almost because tell patients, I say, I'm sure you have friends that eat whatever they want and never gain weight. And other people look at a donut and gain 5 pounds.
Yeah.
That's the exact line. And the patients shake their head, right? And they can relate that to metabolism as just something we were given genetically. And I mean, there's things we have to do. So you may be the person who has to watch what they eat, all those factors. And it's the same way in dental. Don't feel guilty.
Yeah. Well, even though you're not heavily scripted, I just benefited from you sharing some of those things you routinely say. And I can see how it comes from your philosophy and your mindset of, hey, I'm going to be in this with you. This
Yes.
may not be your fault. Let's discover what's going on. Let's prevent it from happening. You might be different. I mean, you really do have these nuggets of great conversation, right?
Yeah.
That get you on the same side as the advocate for care.
Yeah. And our script in our office is in the front end explaining the philosophy, right? So
That sound like.
yeah, so we come in and we basically say, in our office, we're going to look at these 5 main areas. We're going to look at your bite and jaw joint, teeth, gum and bone. We're even going to look at growth and development and the aesthetics. We're going to look at your potential for problems because everyone has a different potential for problems. And when you come in our office, we kind of take a medical model approach because we're going to say, if we can take that potential for problems, what do we do to lower that potential?
Mm.
Does that make sense? And then they say yes. And then so afterwards is when I start going into those certain things. When they're high risk for caries and not perio, I might use the diet analogy or vice versa. I'll use analogies when I talk about termites being an infection that they have in their mouth, and I've given that in a couple speeches, but then I individualize it to it, but it's always lowering risk and it's always on their side. It's never a blame game.
Boy, I can see if you're role playing that with your team, why it takes 5 hours a month. And why you would wanna spend 3 months on perio. I mean,
Yeah.
yeah. Wade, such a joy being with you always.
Thank you much.
You have definitely built an investment grade practice. You are a terrific leader. You are an amazing clinician and a really good friend. So thanks for being here today.
Well, thanks for having me. It's fun.
Thank you for tuning in to this episode of Investment Grade Practices Podcast. If you find value in this episode, help us spread the word by passing it along to a dental friend, subscribe, and give us a like on iTunes or Spotify. Learn more about building your investment grade practice at productivedentist.com today.